Hi everyone. For my research article and review assignment, I chose to touch on the topic, cover the topic of mental health disorders and the juvenile justice system. The article I chose is from the Journal of the American Academy of Psychiatry and the Law Online. It is titled Commentary: The Role of Mental Health Services in Pre-Adjudicated Juvenile Detention Centers, and it is authored by Scott Migdal, LCSW, and Judith P. Robbins, LCSW, JD. To start out, the role of pre-adjudicated juvenile detention centers in treating children and adolescents with mental health needs has continued to receive attention in the literature and nationally. In 2002, Teplin et al. Reported that up to 75% of youths in juvenile detention centers in the United States had one or more psychiatric disorders. While Grisso suggests that the prevalence rates for mental disorders may be higher or lower, depending on how the term mental disorder is defined, the consequences of untreated mental illness and/or substance abuse are clearly of great concern to us all. Mental health services in juvenile detention centers. Can we sustain the positive effects? Many practitioners and researchers have made significant contributions to the literature in this field, taking into account the complexities associated with providing services in these settings. Examples of some of these efforts include work on practice parameters, intake and screening procedures, and innovative juvenile detention programs. The National Center for Mental Health and Juvenile Justice has also provided critical support to practitioners, while the National Commission on Correctional Health Care, NCCHC, has extended a guiding hand through its work on juvenile mental health standards. So how can we then ensure that the positive effects of this mental health movement will continue? Grisso states that we cannot depend only on short-term initiatives by government and/or advocacy groups. Instead, he looks to the development of alliances between juvenile justice and mental health agencies, as well as a potential restructuring of public agencies to improve the fulfillment of children's mental health needs. As practitioners and administrators in the field, we could not agree more with this viewpoint. In concert with these efforts, advocates and policymakers should also take this opportunity to capitalize on the contributions that have already been made by Rausch and the National Juvenile Detention Association. NJDA became one of the 4 founding members of the National Partnership for Juvenile Services, NPJS, in 2004. Rausch and the NJDA had long utilized the term helpful services to define the essential work of the JDC and had included mental health services under the umbrella of helpful services. Is it worth noting that when mental health services were becoming established in many juvenile detention centers, generally over the past 10 years, being reviewed by the NJDA as essential to the juvenile detention centers' continuum of services was extremely important. In effect, this inclusive definition provided a conceptual grounding for professionals working in the field. In 1989, the NJDA defined juvenile detention centers as providing a wide range of helpful services that support the juvenile's physical, emotional, and social development. Helpful services include education, visitation, communication, counseling, continuous supervision, medical and healthcare, nutrition, recreation, and reading. Juvenile detention includes or provides for a system of clinical observation and assessment that complements the helpful services and reports. The juvenile detention mental health movement. To understand better the driving forces and dilemmas facing the juvenile justice system, we must review Grisso's discussion of the 4 phases of the juvenile justice and mental health movement. The first phase, in the beginning of the 20th century, was marked by a parens patriae, or a period of time when judges acted as benevolent parents, figures concerned primarily with the best interests of the child. Phase 2 began in the 1960s and signaled a shift away from parens patriae toward due process. Cases such as Kent versus U.S. and In re Gault were principally responsible for these changes. Phase 3, beginning in the early 1990s, was born out of society's fear of the dangerous delinquent superpredator and espoused to the view that these youth could not be rehabilitated. This perspective, coupled with the collapse of the children's community mental health system, contributed to the influx of children in juvenile detention centers. Since that time, ongoing concerns have been voiced that the juvenile detention centers have become places to deposit youths unable to receive community mental health supports. A 2004 congressional study raised just this concern, noting that youth are being warehoused in juvenile detention centers across the country while awaiting community-based mental health services. Finally, the current movement, Phase 4, began around 2000 and has focused on incarcerated juveniles' mental health needs. Child advocates have also been vocal that the punitive excesses of the super predator phase ignored or even potentially exacerbated youth's mental health problems. Treatment and the ongoing questions regarding role and mission. A subject currently debated by correctional mental health professionals is the definition of treatment as specifically applied to the pre-adjudicated juveniles. Penn and Thomas's work on practice parameters provides critical guidance regarding the challenges of clinical work in juvenile detention centers, including but not limited to intake screening, monitoring and evaluation, the role of psychotropic medications, and the complexities of the clinician's role in adapting to the juvenile detention center environment. While some mental health professionals may still see clinical interventions in a time-limited, non-milieu-based settings as inherently less than, this type of guidance has helped many clinicians working in juvenile detention centers to see their work as merely different and even as ripe with potential benefits to detainees. Yet despite attempts to adapt mental health services specifically to juvenile detention centers, opinions still vary about the juvenile detention center's essential functions, as well as the emphasis that should be placed on either function within the juvenile detention center, including helpful services. Earlier in this article, we reflected on the NJDA's definition of helpful services, including their focus on the integration of safe custody and service provision functions. However, despite sensibility of the NJDA's definition, Rausch notes that the contradictory definitions of juvenile detention are still a central problem for juvenile detention administrators. As evidence, he cites a study in which administrators reported that custody was the most significant function of detention. In this context, the resolution of what Rausch describes as a paradox in our understanding of the juvenile detention center's role and function is a necessary first step for the movement. Custody and service functions must become conceptually integrated and accepted on a larger scale as an alternative to historic treatment versus custody, custody rhetoric. Without this work, juvenile detention centers run the risk of being a place that is merely the object or outcome of the juvenile court action. Moving forward, we have no longer have to argue about whether juvenile detention centers should provide custody or therapy. Instead, they can provide both mental health services and safe custodial environments, as mandated by the accreditation bodies and legal standards. National accreditation organizations support this integration of functions. For example, healthcare standards promulgated by the National Commission on Correctional Healthcare, NCCHC, encourage interdisciplinary collaboration in healthcare delivery as exemplified by their standard on special needs treatment plans. These plans involve all juvenile detention center staff, including mental health professionals, in providing individualized supports for detainees with special mental health needs. Treatment in pre-adjudicated juvenile detention centers does not necessarily mean lesser care, but rather care that is carefully considered, does no harm, and is tailored to the realities of a legally focused host environment. Apart from the high rate of mental health disorders found among detainees, we cannot forget that detainment alone is a significant stressor. While the pre-adjudicated juvenile detention centers will necessarily maintain its primary identity as a setting to manage detainees safely before court disposition, helpful services can clearly be integrated and individualized according to detainees' needs. It is a time to build on the helpful practice parameters developed by Penn and Thomas and related literature to bring our best thinking, research, and practice together in open dialogue on the local, state, regional, and national levels. Further, in collaboration with juvenile justice administrators and judges, we can develop innovative mental health blueprints uniquely adapted to pre-adjudicated juvenile detention centers. The more that juvenile justice and mental health professionals collaborate in developing practical, well-integrated mental health services in juvenile detention centers and make these models available across jurisdictions, the more sustainable the juvenile justice and mental health movement will be. The question of how we can fully operationalize this new call to action is complicated, but given Grisso's insightful analysis, we are awakened to the fact that sustaining the effect of the present reform movement inevitably rests on our collective shoulders. Progress will require collaboration among correctional healthcare organizations, universities, local, regional, state, and national municipalities, and other stakeholders. We are thankful to Grisso for showing us that the time has come. Again, from the American Academy of Psychiatry and the Law. Thank you.